Hello everybody. Thank you for joining in to my uh, quick little lesson on acute respiratory distress syndrome. My name is Jason Semrod. I'm an EMT, also a paramedic student at SCC in Lincoln, Nebraska. So what in the heck is it? So acute respiratory distress syndrome, it's ARDS for short, the acronym, is an acute diffuse inflammatory lung injury that's caused by diverse pulmonary or non-pulmonary etiologies. So what in the hell does that mean? Well, what it is, it's a rapid developing, life-threatening condition in which the air or the lung is injured to the point where it cannot be properly ventilated. So the respiration capabilities, the gas exchange between the CO2 and the O2, all that stuff is reduced. Oftentimes ARDS is fatal. It's characterized by the sudden onset of pulmonary edema leading to respiratory failure, which we all know that's not good. There's a lot of other things that can happen, but it being very serious, that's what you need to know now. So why does this even happen? So the most common conditions associated with ARDS are sepsis and infection or infectious pneumonia. So a lot of the time it's the underlying, or all the time, excuse me, it's the underlying problem that causes ARDS to develop. So sepsis being number one, it's the infection in the entire body. Well, then that infection gets in the lungs, and that's when ARDS develops. Well, same with pneumonia. It's infection in the lungs. It could be bacterial, it could be virus. It's not good. But the other common causes include bronchiolitis, aspiration pneumonia, aspiration of gastric contents, major trauma, bruising of the lungs, burns, inhalation injuries. And a lot of times when people get massive blood transfusions, this is for some reason a huge factor when they get the blood transfusions. I don't know what it is, but it causes them to develop ARDS. It's actually quite wild. So pretty much everything causes ARDS. Well, not everything, but a lot of things do. This list could go on for a long time. So a little more detail. So ARDS is characterized by increased vascular permeability, increased lung weight, and loss of aerated tissue within about a week of the insult. So what that means is, so with the increase of alveolar capillary permeability in the lungs, the protein-rich fluid enters into the airspace of the lung where the alveoli should be and where the respiration occurs with the gas exchange. So from the vascular system, that's where all that fluid comes from. So this results in the pulmonary edema, which then results in the hypoxemia from intrapulmonary shunting, could be left to right, right to left, that type of deal, and also ventilation perfusion mismatch, excuse me. So that's what we got going on. So review thus far. So ARDS can be caused by a ton of different things, mainly sepsis and pneumonia. Because of this underlying condition, they develop an injury to their lungs, which makes them likely to leak water. So when the lungs fill up with fluid, that causes difficulty, rapid breathing, which also may present with audible crackles because of the fluid in there. Well, because of that wild stuff going on, the intrapulmonary shunting occurs along with VQ, so ventilation perfusion mismatch causes the patient to develop hyperoxemia. So, well, shit. We got it going on. There's a lot of things going on right now. This isn't really looking good at all. So ARDS can affect all ages, races, both genders. It doesn't really matter. So these are just some statistics that I found. So in the 15 years and older class, an estimated 86.2 per 100,000 persons gets ARDS. Well, doesn't seem like much, but that's a lot. I mean, this is a rare disease, but that's, I mean, getting to where it's not almost as rare. Like, we're going to run into it possibly throughout our careers. We have a lot of people to encounter, believe it or not. So with there being a 38.5% hospital mortality rate, so that's a lot of people. So you have 86 people having ARDS, 38% of them die. That's too many. We got to figure out how we can fix this better. So in the U.S. alone, ARDS accounts for an estimated 190,600 cases of acute lung injury, 74,500 deaths, and 3.6 million hospital days each year. That's a lot of money, that's a lot of deaths, and that's a lot of cases because of this. So it's really not as rare as we think. So the incidence in the pediatric population, so about 2.2 to 12.8 per 100,000. ARDS accounts for upwards to 2.6% of the pediatric intensive care unit admissions. So that number is not huge, but it's there. 8.3 were placed on a ventilator for more than 24 hours. Well, that kind of makes it a little more big deal. And then hospital mortality rate ranged from 18 to 32%. It's a lot of kids dying because of this. So as EMS providers, what are we going to encounter? Well, like I said in the beginning, it's a trick question. Every patient with ARDS can present in a different way depending on the underlying illness or injury that caused ARDS in the first place. Well, the onset may be rapid, just in a few hours, or it can have a gradual onset that takes about a day, 5 days, it could be up to a week to develop. Well, so with ARDS, what would you say our most common symptom is? Well, I don't think you guys would guess it, but it is respiratory distress. Well, ARDS is acute respiratory distress syndrome. So I think inevitably respiratory distress is going to be a part of that. So other signs and symptoms. So early on, the major symptoms are, so you have obviously your respiratory distress, your rapid breathing rates, your low oxygen concentration, you're getting agitated because of you being like hypoxic and hypoxemia. You're going to have audible crackles because there's fluid in your lungs. So if you have sepsis and that's your underlying condition, well, we know that with sepsis, fever is often there. So if you have sepsis, well, you're probably going to have a fever even though you have ARDS as well. So complications of ARDS, they can cause some pretty big problems pretty quick. So pneumothoraces, along with with the pneumos, we have tracheal deviation, less respiration. It kind of is a domino effect. So the lungs are already filled with fluid. There's air leaking out. There's fluid leaking in. So we risk that chance. We're going to have a collapsed lung. So now we only have one lung that's full of fluid, trying to oxygen our entire body, trying to get rid of our waste, our CO2. Well, it's just going to get worse and worse. Like ALS, we need to be there now. We need to be there yesterday, honestly. These people, they need interventions. They're going to need a needle if they have a pneumothorax. There's a lot of different things we could do. So decreased cardiac output. So them being, they get shocky. So when you get shocky, well now that's really when you're going to start seeing your altered mental status, and everything like that is just going to continue just to get worse and worse because nothing's getting better. Everything just keeps getting worse. Renal failure might be the primary illness that caused ARDS to happen, or it may occur secondarily as a result of the poor cardiac output, the necrosis to the tubular and all this stuff inside the kidneys. You can get multiple organ, you can get MODS. Everything just falls apart. Once it starts, it seems like everything goes south in a hurry. So this will probably fix itself, right? I mean, you can go to the bar, you can have a problem, have a couple beers, well, seems to work. Well, probably not here. That's probably not the case. So we're going to assess and intervene. So treating these patients isn't as wild as it sounds. So we're paramedics, we're going to be paramedics, so we got to do an assessment. So we got to start from the basics. We got our GLC. So general impression, do they look dead? Do they look almost dead? Do they look like are they dying? Or are they alive and well? Well, then we got to check our level of consciousness. So are they alert and oriented? Are they alert and oriented ×1, ×4? Do they know who they are, but they don't know where they are at? Well, that's signs that's when we're going to start seeing our hypoxia and that kind of thing is where we're going to start judging this. So are they alert but they have altered mental status where they're just completely out of it? Are they responsive to just verbal stimuli? I mean, you got to yell at them like, hey, listen, like, hello, and then they'll finally respond to you. Are they going to be responsive to painful stimuli? Do we got to give them a sternal rub? Do we got to pinch traps? So do we got to, like, what do we got to do to get these patients to respond to us? Or are they just plain out unresponsive? So that, if they're unresponsive, that means that it is not good, that things are bad. So then we got to gather the chief complaint. So are they complaining of difficulty breathing? Do they just have a headache? Do they even have a complaint because maybe family called him because he's acting funny? Well, maybe he doesn't even recognize that something's wrong right now. He probably just felt like he was sick. So then we got to go to the ABCs all the time. So airway. Is it patent? Can they properly manage it alone? Or is it time to step in already? Breathing. So we need the rate and quality. Are they 30 and shallow? The SpO2, is that at 88%? What do the lungs sound like? Are they full of fluid? Are they diminished on one side? I mean, are we finding indications of a pneumothorax? Do we need to initiate mechanical ventilations right now? Circulation, do I have good peripheral pulses? No? Well, I better start checking the pressure. If I do, are they weak and thready, rapid and bounding? I mean, we just got to do our assessment. And then we got to make a transport decision. Do I stay and play, or do I load and go? So once we make that transport decision, we just got to stick to it, and we got to do it. So the airway. So let's give it like a little scenario. So say the airway is bad. He's becoming extremely hypoxic. Breathing is rapid and labored. Lung sounds are they have crackles. He's full of fluid. Circulation. He has a weak but present radial pulse bilaterally. So our pressure is not too bad because we have that peripheral pulse. So we have about 114 over 76 blood pressure. Heart rate's 98, a little elevated. SpO2 84% on room air. That's not good. That's what I'm going to probably fix first. So this patient, with everything that's going on, his lung sounds, he has them. He has bilateral lung sounds. He's a perfect candidate for CPAP. There's no contraindications. His pressure's good. Both of his lungs, we have lung sounds. He may be altered, but he can manage his own airway. He can hold that mask to his face. Like, he can obey commands. We just got to remember our indications, contraindications. So if we do give him the CPAP, that continuous pressure, that's going to help force some of that and hopefully a lot of that fluid back into the vascular system from the lungs. Get that fluid out of there. That way we can get that good respiration. We're getting the ventilations in, but we need to get the respirations in good too. So then the 100% oxygen, that will help with him being hypoxic. The low SpO2, that needs to get back up. We need to get more oxygen in his blood right now. So maybe this patient isn't so lucky. Maybe he's in respiratory failure at this point, or really close, extreme respiratory depression. Well, we probably need to take over this patient's airway and breathe for him. Are we going to RSI this patient? I mean, that's something that we got to think about at this time, because if we don't do something, it's only going to get worse, and he's going to get sicker, and he's eventually going to die. So let's recap. So it is important to recognize ARDS. There's a lot of serious complications that can happen because of ARDS. There's also many different presentations that we're going to see, a lot of different signs and symptoms, the causes. I mean, there's not just one thing that causes ARDS. The groups experiencing ARDS, I mean, we can have pediatrics like as young as 2 years old, and they can have pediatric acute respiratory stress syndrome. It used to be where it was only adults. Well, then they changed that because they were finding out that the pediatrics were experiencing these same things, and it was the same disease, basically, that same syndrome, that acute respiratory distress. So as a medic or an EMT or whatever, we got to perform a great assessment. We got to treat our patient. GLC, ABCT, that's like my go-to mnemonic. You get used to saying it. GLC, ABCT. General impression, level of consciousness, chief complaint, airway, breathing, circulation, transport decision. We got to make those. That's our primary assessment. That's got to happen now. It's got to happen quick. It's got to be efficient. It's got to be accurate. That's really important. I think if we can do those, well, then that secondary assessment later, we're already going to have an idea. We're already going to know what we want to do. We know if it's serious. We know if we got to get on the road or not. That's what I always do. And I just want to leave you guys with Shrek is love. Shrek is life.